apologies for being away for some time. I was on service and then on a brief vacation, and glad for my first thing back from this brief long weekend to be with you all and see warm up my neurology mind before getting back to work here. So it would be great to have 2 volunteers to discuss a case, and if someone wants to present a case, that would be fantastic as well. So we'll open it up there and see if anyone would like to volunteer. If you've not been here before, a case will be presented part by part, and you'll have a chance to discuss it with me, and we'll go back and forth. It's fun, it's safe space, it's low pressure, just to work on your clinical reasoning. And so if you have a neurology case you'd like to present, that would be great. If you would like to be a discussant, we'd like to have one discussant identifying as a man and one identifying as a woman. Anyone like to participate? If you're thinking, oh no, it's neurology, I thought it was something else. I don't want to discuss a neurology case. So that's all the more reason to discuss a neurology case. You will remember it for having the chance to discuss it. And it's a lot of fun. If you're thinking, well, I'm not sure, English isn't my first language, I'm not sure I'm ready to discuss a case. Don't worry, we have a very multilingual community here. Hablamos Español. We have people who speak Portuguese, countless other languages here. We can help you out if you need something translated. Who'd like to volunteer to discuss a case? It's a lot of fun. Let the awkward silence begin. I could reflect on a past case, but that would end the awkward silence. Great, Kirtan, thank you very much. I know you have discussed a case before and did a fantastic job. We'd be happy to have you again, but appreciate you giving the chance. If others who have not volunteered before would like to discuss, happy to have you. Otherwise, if not, you'll be up, Kirtan, and it'd be great to have someone to discuss with Kirtan. Anyone like to discuss? I can discuss. Matthew, that's great. We have, I think, 2 men right now, and ideally we'd like to have 1 man discussant and 1 woman discussant. Would any of our participants who identify as a woman like to discuss the case with us? And does anyone have a case? All right, we'll help out with the case part. Either Gabby or Doug, one of you who'd like to present a case would be great. Anyone like to discuss a case here? And Raphael, you have a case also. Great. We have cases, so that's good. What we need is discussants. Great. We have many man volunteers, which is great. We would love to have someone identifying as a woman if possible. Anyone? So I think we got now several volunteers. Let's see, Matthew, anyone? Give it another minute of awkward silence. All right, Kirtan has pulled out, which is fine since you've done this before and we have 2, but I believe 2 men. Any women like to discuss a case with us? All right, the minute is up. We will take Raphael and Matthew. And Doug, Gabby, Raphael, does one of you decide who wants to present? Do you want to present 3 cases at the same time, and we'll have a neurological fugue this morning and see if we can keep track. Now, whoever has it feel they have a case that's sort of ready to go, or if someone wants to sit back and watch either is fine. In the meantime, Raphael and Matthew, could you introduce yourselves? And by the end of that time, I'm sure we'll have a great case to discuss.
Hi guys, I'm Raphael. This is my first time discussing. I'm from Brazil, 4th year of medical school, and neurology, I think it gets out of my comfort zone, but I'll try to do my best and discuss the case.
Fantastic. Well, thank you for volunteering and welcome. And Matthew? Are you still there, Matthew, somewhere? If you're talking, you might be on mute. Did we lose Matthew? I don't see him. Are you still there, Matthew?
Yeah, I don't see him on anymore.
Okay, if not, Kirtan was a backup, but has anyone now been inspired by Raphael's courage to come out of his comfort zone, would like to join him?
Matthew's back.
Yeah, he's back.
Oh, saved by the bell. Okay. Are you there, Matthew?
Yes, a little technical issue, I guess.
Do you mind introducing yourself?
Yeah, hi, I'm Mathieu Brucunet. I'm an emergency physician and trauma team leader in Montreal, Canada.
Great, fantastic. So Canada, Brazil, and Doug is in San Francisco. So welcome, and we'll get started. So Doug, if you just want to give us the chief complaint alone for us to discuss, that would be great.
Sure. Good morning, everyone. Even right at this moment, I'm deciding between 2 cases. Let's see. Let's talk about okay, so the chief complaint will be progressive gait difficulty and falls.
Progressive gait difficulty and falls. So Raphael, where would you start with this one?
I don't know. Maybe we can look for 4 major things: vascular, infection, neoplasic, or trauma. We can search from some problem in the cerebellum. I don't know, some central problems, or I don't know. I would like to maybe do some tests like Romberg.
Great, good start. So you're identifying that gait difficulty can have a number of different localizations, right, in the nervous system. There could be a cerebellar problem that could cause difficulty with gait. You mentioned the Romberg test, and the Romberg test, do you know what that would be a test of, Raphael? What function of the nervous system is being tested by Romberg test?
I think it tests if it's a central or peripheral, not central ataxia. If
That's
you close your eyes.
Yes, go ahead.
No, go ahead.
No, go ahead. How would you do the test?
If you close your eyes and you say to the patient to close his eyes, and if he gets difficult with gait when he closes his eyes, it is a peripheral ataxia.
Yeah, most of what you said was correct. I'm just going to help you with a few things there. So you're right. What you do with the Romberg test is you have the patient close their eyes. First, you have them put their feet together. Some patients can't even get their feet together. They're so unsteady, and that would tell you something. We'll see if that ends up being important later. But then if they can get their feet together with their eyes open, you have them close their eyes. And if they start getting unsteady and take a step, that's a positive Romberg test. And that's actually a test of proprioception. I find that many medical students around the world either learn or are taught that it's a cerebellar finding. It's not a cerebellar finding, it's a finding that has to do with proprioception. Because if you can use the vision to overcome the loss of proprioception, you can keep yourself steady with your eyes open. But as soon as you close them and lose the visual sense, you're relying on proprioception, which comes through the nerves, through the dorsal columns, up to the brain. So it could be a lesion anywhere along that pathway. So great. So two possibilities for how we could have gait dysfunction are cerebellar ataxia or a problem with proprioception. There are others as well. So let me have Mathieu give us some thoughts on the approach to gait difficulty, and then I'll add some of my thoughts as well.
So I would take a step back and say that there's a couple of steps that we need to go through before we're allowed to talk neurology. I mean, most people come to the emergency department for a leg weakness, and then it turns out to be sepsis or anything else. So I would make sure that it's we're talking about gait difficulty, not the unspecified leg weakness that turns out to be asthenia, which then has a super broad differential diagnosis. So that would be the first thing. Second thing is there's a notion of falls here. So I would like to know, when was the last fall? Is there any traumatic consequences from those falls? And once I've checked those two boxes, then I would focus on the gait difficulty.
Fantastic, great thoughts, Mathieu. Both thoughts in general, how you would approach gait, and then as you see it as an emergency room physician. And that's going to be important here to hear if this patient has arrived in the emergency room, either due to a fall or a very rapidly progressive gait disorder, or whether we're seeing them in the clinic, and this is something more chronic. Of course, the fall may have been an acute event that's representative of a more chronic progressive problem. And those are things we'll find out when we get more than 5 words to play with. But these are great points. Let me sort of synthesize them a little bit and add a few things. So when we talk about gait, right, gait is a very complicated neurologic function, right? And it requires a lot of systems working together. And so we test gait at the end of the neurologic exam because it's in a way synthesizing all of the functions we've tested previously, right? So as Mathieu mentioned, we have to even start outside the nervous system, right? There could be an orthopedic problem that could cause gait difficulty, right? The patient could have osteoarthritis of the hip or knee. They could have some type of problem of the spine or something like this that could cause difficulty with the gait. And as you said, the patient may come in with sort of weakness, which we refer to as asthenia, rather than true sort of neurologic weakness, as in a deficit in strength, and have some systemic issue that's making them feel very weak. And since gait is a stress test of one's sort of ability to use one's strength and coordination, maybe they're pretty good until they get up to walk, and then because they're anemic or because they're orthostatic or a whole host of medical problems that could cause them to call the difficulty with which they're presenting one to do with gait, when in fact the gait is just sort of the end result of some systemic problem. But probably, since it's Neurology Morning Report, right, this will be a neurologic issue that we're going to be discussing. But as Mathieu said, we first need to think about the larger context in which gait occurs, and that requires other organ systems to be functioning well as well. So now when we get into the nervous system, you know, as we go through the neurologic exam, right, we test the mental status, cranial nerves, motor system, sensory system, reflexes, cerebellum, and gait. And really, problems with any of those symptoms can give us gait difficulty. So as Mathieu already alluded to, if there's just weakness, right, there could be problems with gait. And again, gait is sort of a stress test, right, of all the nervous system's functions working in symphony, right, to give us our gait. So if the patient has weakness, and we've talked about weakness on other mornings, right, that could be a problem in the corticospinal tracts, that could be a problem in the nerve roots, nerves, neuromuscular junction, or muscle, that could cause the patient to have a problem with their gait because their legs are weak, right? And we'd have to do our upper versus lower motor neuron signs and look for symmetries and asymmetries, patterns of weakness, proximal, distal, all of those sorts of things to tease apart weakness, right? So then moving down, we could also have sensory dysfunction, right? Raphael started telling us about the Romberg test, and we talked about that being a test of proprioception. If your sensory function is not very good in your feet, right? You might have a lot of trouble with gait. Think of yourself walking on the ice, right? You don't get that. Those of you that live or work in places where there's ice, right? If you've walked on the ice, you have to be very careful because you're not getting the normal sort of signals of rebound from your feet going on pavement or grass or wherever we usually go, or if you're walking on very unsteady territory, right? So if your proprioception is off, you might be perfectly strong, but you would have trouble with your gait due to sensory dysfunction. Raphael mentioned the cerebellum, right? The cerebellum coordinates our movements. And if we have perfect strength and perfect sensation, but we can't coordinate the functions due to a cerebellar problem, there can also be gait dysfunction as a result of that. And then that sort of takes us through the elemental nervous system exam, but coming back up to the top again, what if this patient has some higher order problem with gait? By which I mean, what's causing the problem with gait, for example, in Parkinson's disease or in normal pressure hydrocephalus, right? These are conditions that affect the gait due to different mechanisms that are sort of higher order, what I call, in using a modern metaphor, the Gait app, right? You can have all of your systems working on your phone, right? But you need the Gait app to coordinate them and tell you to walk, right? To generate that rhythmic pattern of walking, right? So for example, in normal pressure hydrocephalus, due to the expanding ventricles, there's presumably some disruption of frontal circuits that are needed for this very complex function of gait. I call that, when I say strength is normal, coordination is normal, sensation is normal, patient doesn't have a Romberg test, yet there's something not right with their gait. I wonder, is this a problem with the Gait app, right? That's sort of my term. You won't see that in a book, but sort of a modern metaphor, right? Is there a problem with the Gait app? For example, in normal pressure hydrocephalus or in Parkinsonism or Parkinson's disease as a subset of Parkinsonism, some problem with the basal ganglia, which are involved in higher order motor control, including gait. So we can have a problem anywhere in the nervous system, as Matthew told us, even outside the nervous system, causing problems with gait. And there are particular patterns we can see on the exam, which we'll probably get to later, which can help clue us in to particular etiologies. But of course, we're going to want to make sure there's not an elemental problem with motor, sensation, cerebellar, or otherwise along the way. So as we know, we like to think about neurology in terms of localization and time course. We have a lot of homework to do localization-wise, right? Because this can be a problem anywhere in the nervous system. And then, as was alluded to by Matthew, right, if this patient is presenting to the emergency room, are they presenting for a brand new problem or a rapid onset problem or the acute manifestation of a chronic problem? Or is this in the clinic and it's a slowly progressive chronic condition? So our differential diagnosis is broad based on these 5 words alone. And let's see, as we go now through the HPI, if we hear stories of weakness, sensory loss, incoordination, or other clues that are already going to start helping us with the localization. So give us a few more words, Doug, and feel free at your discretion to give us the HPI and past medical, et cetera, up to not including the exam, or if there's interesting information that you think is better for teaching to withhold, that's perfectly fine as well.
Sure, and I'll just say for time planning purposes, this initial presentation will be the first of 2 major ones, and the second one will be important as well. So we will want to save time for that. So this is a 60-year-old man with a history of a right Bell's palsy 15 years ago, hypertension, chronic headaches, who comes in with a week of kind of just like what started as nondescript difficulty walking, feeling like his right more than his left foot was kind of getting caught on the steps when he was walking up the steps, and more recently on the carpet. There was also some, he was also noting concern initially about, in the past few days before he came to the emergency room, some lower extremity burning and some mild back pain with occasional radiation down his legs. He says that, the pain is kind of cramping, really nondescript, kind of variable. It's kind of the same on both legs. It's not, it's worse when he's up walking, but recently it's been even there, kind of waking him up at night occasionally. It's never gotten too terribly bad, but he really came into the emergency room because he had his 3rd fall the other day when he kind of caught his toe on the stairs, and this pain really wasn't going away, not responding to Tylenol or ibuprofen. And he had one episode of what he called urinary dribbling, which had never happened to him before and was very concerning. He had no problems with fecal continence. He had no other kind of systemic or constitutional symptoms that he could talk about. He'd had no trauma. There was no, nothing above the neck, as we say, no diplopia, no facial numbness, no involvement of his arms, no changes in his vision, no headaches or stiff neck. I will say that his past medical history, as I mentioned, just had a right Bell's palsy that was remote, hypertension, had an umbilical hernia many years ago, but had never had any surgeries. Medications were just some blood pressure medications, lisinopril, and a multivitamin. There was no significant family, or actually I'll say there was a family history. He has a son with Crohn's disease, but no other known history of autoimmune disease in the family. He had one relative who had a major stroke in the past, and a brother who had died of a blood clot 10 years ago to the lungs. The social history, lives at home with family, worked previously as an administrator in a hospital, had not had any exotic travel recently, lives in Northern California, and likes to go camping. Maybe I'll stop there.
Great, lots of information there. Mathieu, you'll be up first this time, actually, since there's a couple of aliquots of history. It sounds like I'll have you discuss here, Mathieu, if that's okay with you, and Raphael, you'll take the next chunk of information.
Yeah, sounds good. So I think that the most pressing things to rule out given his presentation is going to be some form of acute myelopathy, which has a large differential, could be compressive, could be inflammatory, but that would be the first thing to rule out given his bilateral leg symptoms and and especially the urinary dripping, when put together with the other findings, seems to point to the spinal cord. So that would be the first thing to investigate. If it wasn't for the urinary dripping, I would still think myelopathy, but I would keep in mind that if I don't find anything there, in the spine, then another possibility would be some peripheral demyelinating disease like Guillain-Barré. Sometimes Guillain-Barré presents with radicular pain, which can IPS, and they sometimes describe it as IPS or lumbar pain, which can give you a kind of false localization. But first thing to look for is a myelopathy, and then if you don't find anything there, I would be ruling out GBS in a second.
Yeah, great thoughts. So we hear bilateral legs. Doug, correct me if I'm wrong, nothing in the arms, right? You said nothing above the neck, but nothing in the arms, right?
No subjective arm symptoms.
Right. So thank you. So if you have bilateral legs, right? So your main differential diagnosis here is spinal cord and below, right? Spinal cord, nerve roots of the cauda equina, peripheral neuropathy, rarely neuromuscular junction muscle, because those should affect the upper extremities as well. And then very rare, but you can sometimes get faked out by a midline cerebral lesion affecting the bilateral leg areas. Remember, the homunculus has the big hands on the side, and then, the big face on the side, then the hands more medial, and then the most medial is the legs, right, dangling in the interhemispheric fissure. So a parasagittal meningioma or bilateral ACA strokes could give you lower limb involvement with nothing in the upper limbs or minimal in the upper limbs. That could be a fake out, but in general, you're thinking spinal cord and below. And brilliant points there, Mathieu. And I also want to recognize that Mathieu told us the correct pronunciation of Guillain-Barré, which many of us have pronounced incorrectly as Guillain-Barré. But Doug sent me a wonderful video of one of my former mentors, or can still mentor, but someone I worked with in my former institution who's extraordinary neurologist and expert on Guillain-Barré, and actually went and found Guillain's grandson, was it, Doug, if I remember correctly, in Vermont, who told him that correct pronunciation is Guillain. It's not Spanish, it's French. So we heard it from a native French speaker from Montreal. So teaching point today, Guillain-Barré, people will tell you on rounds you pronounced it wrong. That is the correct pronunciation. You heard it here. So thank you for putting it that way, and great points. So, so there's a lot of interesting stuff here. What do either of you make of this fact that the feet are getting caught, Mathieu or Raphael, does that help us at all here in terms of what's actually weak, why he's having trouble walking?
Well, that could point to a proximal weakness more than distal, I believe, but I'm not sure that in real life I would give too much attention to it.
Okay, yeah. So when I hear that the foot is getting caught, that makes me think. So another, we could spend hours and hours talking about gait. But when you walk, you need to dorsiflex your foot so you land on the heel, right? You have a heel strike and then your foot proceeds forward, and then you plantar flex to push off, right? So to have that heel strike, you need dorsiflexion. And if you're not dorsiflexed and that foot is dragging a little bit, it can get caught. That's a foot drop, right? And the localization there is either the perineal nerve, the sciatic nerve, which is really just the perineal and tibial bound together, an L5 radiculopathy, or very rarely a central lesion. So this sounds to me like there's a foot drop here. If the feet are getting caught, the feet are getting stuck. So that's one thing that sort of jumped out at me. And then there's this pain that's burning. It sounds neuropathic. It's radiating down the legs. Makes us think of a nerve root problem. And Mathieu, you made the excellent point that Guillain-Barré, although sorry, I said it again. I just heard this video last week. Guillain-Barré, it's hard after so many years of pronouncing it wrong. Guillain-Barré is not just a acute neuropathy. That P stands for polyradiculoneuropathy, and AIDP, acute inflammatory demyelinating polyradiculoneuropathy. So it's the roots and the nerves. So you can certainly get pain. And one of my first patients as a resident with Guillain-Barré told me the pain, the radicular pain she had, was worse than the pain of childbirth, was her way of describing it. So this can be a painful illness. So that's certainly worth thinking about. And that radicular pain, along with the fact that this is somewhat asymmetric, at least according to the patient, and seems to be focused particularly on the feet, although we'll see, would make me think a little more of the cauda equina than the spinal cord itself, because there's that radicular pain. And while you can get back pain with a myelopathy, a spinal cord problem, I wouldn't expect this radiating pain per se. And the urinary dribbling, again, it would be very atypical, very uncommon to get any sphincter dysfunction with Guillain-Barré, but it is very rarely the same person I'm referring to. Dr. Alan Roper is one of the world experts on this topic, as you can get a little bit of urinary retention, but it shouldn't be a major feature. So that would make me a little bit move a little bit away from Guillain-Barré. So I think that's where we are right now. It sounds like the falls are due to weakness in the feet. There's also pain that's sort of radicular. And so this is sort of zooming me in, at least on the cauda equina with those symptoms, and then the urinary aspect on top of that. Great, Doug. So you said there's more history before we get to the exam, or something else happens?
No. I think the next step would be the initial exam, and then some of the imaging and workup that happens.
Okay. Perfect. So before you give us the exam, we have sort of a presumed localization, but there's a couple possibilities. Spinal cord or spinal cord plus roots is probably not ruled out. Raphael, as we move into the exam, if we're thinking that this could be spinal cord, nerve roots, nerves are probably the main localization. What tests would be most helpful on exam to help us figure out, is this in the spinal cord or is this below in the peripheral nervous system? Raphael, do you have any thoughts?
We can do a electroneuromiography.
So before we get to the test, yeah, on the physical exam, I'm sorry, I know exam sometimes translates differently, the physical examination, yeah.
Okay.
Sorry, that was my fault. Yeah, I know exams, when we say exam, we mean the physical exam. In other languages, examen, right, is the technical exam, the laboratory diagnostic exams, right? So yeah, on the physical examination, what would help us distinguish between a problem in the spinal cord versus below in the peripheral nervous system?
I think the reflexes, like Babinski reflex, if you have a hyperreflexia, it means it is a central lesion. If it's normal, is a peripheral lesion.
Fantastic, right? So when we have weakness, and there is weakness here as part of this, we want to determine if it's upper motor neuron or lower motor neuron. The upper motor neuron is the central nervous system component going in the brain, brainstem, and spinal cord. And the lower motor neuron, though it begins briefly in the spinal cord, is really the nerve root and nerves on the way out. And upper motor neuron signs, you remember my mnemonic, make everything go up. So you get an upgoing toe, hyperreflexia, increased tone, right? And lower motor neuron signs, things go lower. You get decreased or absent reflexes. You get a downgoing toe, which is a normal sign there. And you can get decreased tone, decreased muscle bulk if this is long-standing. So one important point to keep in mind, I think we've talked about this before in the acute setting, and this is pretty acute. It's been going worsening over days, that the upper motor neuron signs can take time to come out, right? So if this is really an acute myelitis, I heard that term, I saw that term fly by in the chat, right? You might not see your upper motor neuron signs quite yet. They can take some time, and you can get faked out early on between spinal cord and peripheral nerve in that process. So perfect, we'll be very interested in, I think, examining the legs. And if this really looks like an isolated foot drop that's asymmetric, that could be a spinal cord problem, but might make us more concerned about polyradiculopathy. And we'll want to see if there are upper motor neuron signs or lower motor neuron signs here. And then, great, so we'll hear about the exam. That'll help us with the localization. Then maybe after that, we'll circle back and say, once we know where this is, we know the time course and some other clues, we'll have to try to figure out what it is in terms of etiology. But right now, I think we're very focused on the localization. So it'd be great to hear from Doug what was found on exam and see where we land there.
Great. So the neurologic exam, there's nothing really notable on the general exam. Mental status was normal. Cranial nerves was noticeable for kind of trace right upper and lower facial weakness. But otherwise really unremarkable. The motor exam was notable for normal bulk and tone throughout. There was full strength in the upper extremities, including kind of in the distal and intrinsic hand muscles. In the lower extremities, you had relatively symmetric weakness in the following pattern. I'm kind of recalling my own exam, but initially it was about 4+ weakness in the iliopsoas, full strength in the quads, 5 out of 5. The bilateral hamstrings were 4 to 4+ and relatively symmetric. The tibialis anterior in foot dorsiflexion was about 4 to 4-. And then the EHL, extensor hallucis longus muscles were 2s to 3s, quite weak. Those were somewhat asymmetric, a little bit stronger on the right side. Gastrocnemius foot plantar flexion was full. Inversion and eversion were both kind of diffusely weak, and hip abduction and abduction were full. The sensory examination, there was really patchy loss to pinprick, like on the anterior and lateral thighs, and also on the lower abdomen, but no sensory level that we could elicit over the back. Vibration and joint position sense was intact in the toes. Actually, I'm sorry, vibration was slightly diminished, but joint position sense was intact. Reflexes were hyperreflexic in the lower extremities. They were normal in the fingers, and there was no Hoffman sign, but she had, or he had bilateral cross adductor signs and 3+ at the bilateral knees. There was two beats of non-sustained clonus at the right ankle, and there were hyperactive ankle jerks. Toes were equivocal; they were not upgoing toes. And then I don't think we initially tested a Romberg sign. I would have mentioned that in sensory, but the gait was, there was a kind of a mild steppage gait. that was a little bit worse on the left side, as I mentioned, and sort of mildly wide base and unsteady, but didn't have any problem with tandem. Had a little bit of trouble with heel walking. Aaron, you're muted.
I'm muted. I'm silenced by all the information you gave has muted me, and while I'm thinking about this. Great. What are your thoughts here, Raphael, with this new information? And then we'll have Mathieu opine as well. What do you think?
I'm a little confused with the information, but I got that he has hyperreflexic, reflexic, so it means it is a upper motor neuron sign. And if you want to say what you think, Mathieu.
Yeah, great. So great. Yeah, there's a lot of information here that is very detailed in terms of the pattern of weakness, which we can get into. But one thing jumps out, right, Raphael, as you were looking for, is this hyperreflexia or hyporeflexia? We've been saying, is this spinal cord or is this nerve roots, or maybe some of both? But that hyperreflexia sure suggests it's upper motor neuron spinal cord. So great. I think you picked up on one of the most important findings. What are your thoughts here, Mathieu?
So I agree with Raphael that it seems to be pointing toward upper motor neuron lesion. There's bilateral findings. The patchy distribution is a little bit weird, but sometimes, I mean, it can sometimes happen. It makes me think of Conus Mitsularis syndrome. I mean, at this point, I think that would be with the sphincter symptom, bilateral weakness, back pain, upper motor neuron symptoms. To me, that would be the unifying diagnosis at this point.
Yeah, so conus medullaris, the sacral part of the spinal cord, the sort of bottom portion of it there. Yeah, there's a lot of interesting information here. So the hyperreflexia does make us think more of the cord. A lot is made of distinguishing cauda equina syndrome from conus medullaris syndrome. So the spinal cord ends at about the L1, L2 level. And from cervical and thoracic, the level of the spinal cord roots exiting with the named numbered vertebrae is relatively close. But since the spinal cord ends at L1, L2, there's a lot of roots, right, for L1, 2, 3, 4, 5, S1, 2, 3, 4. They're kind of packed into a small part of the cord, and those roots then have to descend to get out of their corresponding neural foramina. So those roots of about L2 and lower are the cauda equina. And the conus medullaris, my understanding, though it's a little hard to find a totally precise definition, but we have some other neurologists who can maybe tell me what they've seen in textbooks or heard from their professors. It's just the sacral component of the cord. And so the sacral component presumably shouldn't cause weakness of the limbs because well, the S1, S2 part could, but S3, 4 below is just sort of going for the sphincters there. So some of the weakness here in the iliopsoas, which would be about L2, L3, would be a little bit hard to localize to the conus per se, but I think this distinction is a little bit academic because the conus and cauda equina are right next to each other, and it's really hard to get one and not the other. But in principle, the cauda equina, since it's nerve roots, if that was compressed by itself or involved in some way, shouldn't give you upper motor neuron findings, right? Because those are the lower motor neurons. However, if you're compressing the cauda equina and the conus, you could get some upper motor neuron signs as well. But if it's really just S2, S1 and below in the conus, if that's how it's defined anatomically, right, then you shouldn't be able to change the reflexes in L3, L4, which is the knee reflex. But that's always been a point of confusion for me. So, and in real life, you know what you're going to image, you know what you're going to look for. So whether it's one, both, or both one, the other, or both, a little hard. But Gabby or Doug, if you have other thoughts on conus versus cauda syndrome, feel free to chime in. But so we have those upper motor neuron findings. The weakness is in a very interesting pattern. So we have the iliopsoas, that's hip flexion. right? We have problems with knee flexion as well, that's the hamstrings. Then we have problems with dorsiflexion. So if we were going to call that a problem with nerve roots, we'd have L2, L3 for the psoas, L4, L5 for the hamstrings, and then L4, L5 again for dorsiflexion, but we're sort of skipping some things between there that were okay, L3, L4 for knee extension, right? So that would be a little bit tricky to have with non-contiguous roots being affected. And then hip flexion is the femoral nerve, but so is knee extension. So why would we get one part of that without the other? You can't, well, all right, I'm not going to go down that rabbit hole right now. Dorsiflexion, right, is the perineal nerve, and plantar flexion is the tibial nerve. So this doesn't really necessarily fit with nerves or roots, but this pattern of hip flexion, knee flexion, and dorsiflexion being affected together is an upper motor neuron pattern. So if you think of the image of someone who's had a stroke many, many, many years later, either a patient you've seen or there's a classic Netter drawing where the arm is held in flexion, wrist flexion, finger flexion, elbow flexion, and the leg is held out straight with the toes plantar flexed and the knee extended, right? And the patient has to circumduct or have that sort of scissors gait. The opposites of those are the upper motor neuron pattern of weakness, right? So difficulty with triceps, which is arm extension, wrist extension, you get the pronator drift because supination is weaker. And then in the leg, you get weaker hip flexion, knee flexion, and dorsiflexion. And when those are weaker than their corresponding antagonist muscles, that's how you get these patterns of spasticity where the stronger muscles sort of win out. I know that can be a little bit confusing and that's a little bit gourmet, but this is an upper motor neuron pattern of weakness. And you can see this when you check for Babinski sign, if you have the full Babinski sign or if the patient is truly paraplegic from an upper motor neuron sign and you apply a noxious stimulus, or even sometimes just from Babinski, you activate all of those upper motor neuron muscles as part of that reflex. You get what's called the triple flexion response of hip flexion, knee flexion, and dorsiflexion. So if those muscles are all weak together, that clues us into an upper motor neuron pattern. So spinal cord looks like it wins the day. The first thing Matthew wanted to rule out for us here. And with the urinary dribbling, paraplegia, I would have gone with that as well from the beginning. It was just that radicular pain that made me think that roots are involved as well. So we might have spinal cord and nerve roots here to get some of that radiculopathy, but definitely upper motor neuron signs, upper motor neuron pattern of weakness. We are concerned here about a spinal cord problem, and the arms are obviously spared, so we're thoracic or below. And right, so we know where we are. Now we have to figure out what we have. So Raphael, Matthew, what are your thoughts on potential etiology here, circling back to the history now that we know where this is, incorporating the time course? While you think about that for a moment, Doug, Gabby, any other thoughts on Conus medullaris versus cauda equina? I find it a very confusing and probably not super clinically useful distinction since they're so close, it can be affected together.
I've heard things about using reflexes to sort of parse out the two from each other, but I think that is muddied by the spinal shock ideas of low reflexes early in, and it's also, I don't think the differential is any different. So I don't know if it really changes anything. Okay. But I agree with you. Ambiguous distinction.
Yeah, I agree with you. I've never, I had the same definition as you did. And I think in practical cases, it's not so much important, although it's interesting.
Yeah, interesting, but yeah, a little hard to tease apart. Okay, so etiology-wise, I think we're back to you, Matthew. What are you concerned about here? This is something that sort of started a week ago and has worsened over the past few days and is presumably a spinal cord plus minus nerve root problem.
So the two big categories would be compression, either by a tumor, an hematoma, a disc, versus some inflammatory process, which would be myelitis, which can be autoinflammatory, infectious, perineoplastic. But first thing to rule out would be a compression. So I think that is now a rip for his MRI.
Yeah, absolutely. So with the spine, we're always worried about compression. The question is compression by what, right? And he gave us some good examples there. There can be disc material, there can be a collapsed vertebra, there can be an infectious lesion like an epidural abscess. There can be vascular lesion like a hematoma or something like that. So anatomically, we can think of lesions affecting the spinal cord as being extradural, meaning between the bone and the dura. We can think of them as being intradural, and then intradural usually divided into extramedullary and intramedullary. So we can have intradural, extramedullary, which are our sort of subdural kind of processes, which could be infectious or blood or inflammatory. And then we have in the cord itself. So all of our categories apply to the spinal cord: vascular, neoplastic, trauma, infectious, inflammatory, et cetera. So we want to look for whether there's compression and whether that's coming from outside the spine, from inside the spine, outside the spinal cord, or inside the spinal cord itself. With that time course, right, probably a little bit slow for some type of hemorrhage, be that epidural, subdural, or the rare intramedullary, truly spinal cord, inside the spinal cord hemorrhage. Compression could be, it's probably pretty fast for a tumor, and probably a little bit slow for vertebral collapse, although there are processes that cause the vertebra to sort of collapse slowly. We're thinking about Pott's disease in many parts of the world, right? So we have a non-traumatic, we presume non-traumatic, we haven't heard yet, maybe Doug is withholding an aliquot that the patient, one of these falls might have broken a bone in their back, fractured a vertebra, and that's sort of progressing now and compressing the cord. But we could have some type of fracture process, right? And then if this is non-traumatic acute myelopathy, we're really in sort of the infection inflammatory category. And so transverse myelitis has become sort of a general name, but in the specific definition is, presumably referring to an inflammatory condition, which could be the first presentation of a disease like multiple sclerosis or neuromyelitis optica, or it could be an isolated post-infectious inflammatory condition. And then you mentioned also perineoplastic. There are perineoplastic myelinities that can be sort of acute to subacute. I haven't seen one, but from my reading, I don't think they tend to be this painful, although I could be wrong about that. And they tend to sort of be tractopathy, meaning they're knocking out particular tracts, like the corticospinal tracts of dorsal columns, things like that. We could have an infection here. Could this patient have an epidural abscess, a rare intraspinal or intramedullary abscess? You might say, well, doesn't have a fever, might not have a fever. Not all of these patients with sort of walled off abscesses in the nervous system have a fever. So many possibilities. And you're right, the first test we're going to want to get here is an MRI, presumably of at least the thoracic and lumbosacral spine, and see if there's anything going on in the bones, anything going on in the cord, and that will help us go from there. So I'm presuming this is going to take us pretty close to the final diagnosis. So let us know what you had next, Doug, and we'll go from there.
Yeah, I'm going to say, I'm going to give you a big chunk of information. We should discuss it, and then we should get to the next big chunk of information, because there will be another big thing to discuss. Cool. All right, well, that was an amazing discussion, an amazing localization. We got an MRI of the entire spine, and there was found to be central cord edema and subtle enhancement, starting at the T8 level down through the conus, and there was thickening and enhancement of the cauda equina nerve roots. There was an incidental finding that I'm going to mention of bilateral hilar and right paratracheal lymphadenopathy.
Wow.
I'll also say that we got an LP, which the LP had a protein of 70 and 7 white blood cells, and was repeated with no intervention in between, and was 4 white blood cells with a protein of 60. And I'll also mention that throughout this time, this is a couple days in the hospital, the patient's symptoms were actually improving spontaneously.
Interesting. Great. So our localization was correct, right? There was spinal cord and there were nerve roots, right? So both were correct. And the clue to those roots was really that radicular pain. And then the clue to the cord was that upper motor neuron pattern of weakness plus the hyperreflexia. Great. Raphael, what are you thinking now with these MRI findings and spinal fluid findings? The
normal protein is 100 to
30 to 40 or below generally. So that's a high protein, not super high, but elevated. Yeah.
So I'm thinking about an infection.
Okay, infection is one possibility. Yeah. And yeah.
Say.
Okay, good. Any other thoughts, or should we have Matthew give his thoughts there? Matthew, any thoughts here?
So it's hard to ignore the bilateral adenopathy. First thing that comes in mind is sarcoidosis. Now we can wonder if it's neurosarcoidosis. We can even wonder if the Bell's palsy 15 years ago was related. The CSF result, that's not infectious, but potentially an inflammatory pattern. So I'm not sure how far does it, like, how much it helps us.
Yeah, great thoughts there. Right, so hard to ignore the hilar adenopathy, but we'll ignore it for a second. So we have diffuse cord edema and we have nerve root enhancement. So the localization is correct, and this is just telling us that there's some type of edema in the cord, right? And we don't know why, if that's infectious, inflammatory, or if that's just engorgement from, say, a dural AV fistula, which is a spinal cord great imitator. We've had cases of that in the morning reports before. Usually it's a more subacute to chronic time course, but can look like transverse myelitis on a scan because there's cord edema, and actually it's a vascular problem. We won't get into that right now. And then thickening and enhancement of the cauda equina. That enhancement tells us the blood-brain, or in this case, blood-nerve barrier is open. So there's something going on there, inflammatory, and that could be inflammation caused by primary inflammatory disease, and infection or a malignancy could give that appearance. So then this lumbar puncture helps us in suggesting this is probably not an infection, right? The protein is not sky high. The white cells are abnormal, 7. You shouldn't, some people say you should only have 0, but certainly less than 5, right? So this is more of an inflammatory picture. And again, that's still somewhat non-specific. So what can cause inflammatory lesions of the spinal cord? We're off to the races, right? Primary inflammation, primary neurologic inflammatory diseases. We mentioned like multiple sclerosis, neuromyelitis optica. We shouldn't expect those to affect nerve roots, right? And then we have systemic inflammatory conditions that can affect the spinal cord and nerve roots. And hopefully, even had Doug not told us about the hilar adenopathy and paratracheal lymphadenopathy, we would have thought of sarcoidosis. Why? Because so sarcoid can do lots of different things in the nervous system. The most common is a cranial neuropathy, and the most common cranial neuropathy is a cranial nerve 7. So Bell's palsy is an idiopathic cranial nerve 7 palsy, right? But it can also be caused by other things like Lyme disease, HIV seroconversion, and sarcoid is in that differential. So what does sarcoid do elsewhere in the nervous system? In the spine, the most common is to see peel enhancement, meaning enhancement of the leptomeninges. And there's this so-called trident sign of the sort of leptomeninges enhancing, and that sort of going into that fold between the dorsal columns. I believe that's why that has that appearance, although Doug works with a neurosarcoid expert, which I should have considered as a clue, Dr. Jeff Gelfand, and so maybe he can enlighten us on that trident sign if that ends up being the diagnosis here. But gee, hilar adenopathy and anything neuro, we think of neuro sarcoidosis. Serum and CSF ACE are not particularly sensitive or specific, though I'm sure they were sent. But to really prove this diagnosis in general, you're going to need to biopsy one of those lymph nodes, which I presume is our final aliquot. What could we get here that could have fooled us? Well, depending on where we were in the world, right? Could tuberculosis do this? Yes, tuberculosis can cause not just Pott's disease, but an arachnoiditis, spinal meningitis, and propensity to the cauda equina. Presumably the CSF would look a little angrier there than it does. I saw lymphoma go by on the chat. That's a great thought. If I see isolated cauda equina enhancement by itself and there's no trauma, there's no compression, I often will wonder about sarcoidosis, tuberculosis, lymphoma as possibilities there. So we're probably going to need to biopsy a lymph node, presumably to confirm sarcoidosis, but lymphoma is certainly on the differential. And then again, depending on where we were in the world, tuberculosis would be numbers 1 through 10 on differential for this presentation of a rapidly progressive myelopathy and or cauda equina syndrome with adenopathy, or even without adenopathy. So I suspect Doug and his colleagues there got some tissue. And is it going to show us non-caseating granulomas or caseating granulomas or a B-cell neoplasm? I'm going to put my bet on neurosarcoidosis, as Matthew suggested, but Doug presents complicated cases that often have a twist at the end, so I'm going to be prepared for something else. Other clues here in retrospect, right? The son with Crohn's disease is a family with a propensity to autoimmune diseases. The prior, quote, Bell's palsy, was that really neurosarcoid of the seventh nerve? So what did you get next, Doug?
Amazing discussion. My team was thinking along exactly the same lines. We went and got an endoscopic guided biopsy of these hilar lymph nodes, which showed non-caseating granulomas. And I'll tell you that before, so the biopsy was collected. It was going to take about 4 days for that path to come back. And over the course of about a 4-day hospitalization, the patient's symptoms had totally resolved. He had a little bit of trace weakness in the toes at this point, but the sensory symptoms had evolved. I'll say he was treated with 2 days of acyclovir while we were waiting for the herpes serologies to come back, but that was stopped and presumably had no impact. We were a little confused by that because, but we did not know about this biopsy while this person was in the hospital. The path came back after they had already gone home, and we could not reach this person for about 2 weeks until my co-resident got this person back into clinic. In the meantime, I had come onto the ward service, and he called me from clinic and told me this story, which I didn't know at the time, and said, this patient came back, I think he has neurosarcoid and he looks bad. He's, and the exam he described to me, and the exam that I eventually got when this person came onto our service, was very similar to the one that we had seen before. There was a little bit more urinary incontinence that had been happening. He'd had another fall without major trauma. And this patient that night, had a very broad workup for a lot of what you all had talked about. There was, we had, sent to quantiferon, Lyme, HIV, syphilis, several, he'd had negative cytology and flow cytometry from his CSF to think about lymphoma, LDH, and all of what you guys mentioned very astutely had been negative. We treated this patient with IV methylprednisolone, and the next morning when I came in, he was completely paraplegic with a sensory level at about T10 and below. I'll say he could just wiggle his toes on the left side a little bit, and now was completely unable to void his urine. And that's where I'll stop that aliquot.
Wow. So just in the interest of time, so the spontaneous resolution would not really be expected for an inflammatory condition that quickly. Transverse myelitis can be monophasic. Flares of multiple sclerosis can be monophasic. So inflammatory conditions of that nature can do so. I wouldn't think with all this enhancement and edema, this would just go away. And then when it worsens so dramatically that the patient is paraplegic and so rapidly, also makes me a little bit weary of neurosarcoid explaining the whole thing. And another little clue here is that the patient worsens with steroids. So you might say, oh, then it must be an infection. It could be. The other condition that causes a fluctuating myelopathy with a lot of cord edema that can get worse with steroids is, as I mentioned before, a dural AV fistula. So does this patient have several diagnoses? So the patient has sarcoid, right? And what we're seeing neurosarcoid, or does the patient also have a dural AV fistula that is now fluctuating and has worsened with steroids, and can also worsen after lumbar puncture? I'm not sure we understand why exactly that is, or at least I don't understand. Or is this just a very malignant form of sarcoidosis that is just progressing very rapidly? But even still, why did it go away and get better? So I think, as I'm sure your team was, Doug, sort of wondering if this is the whole story or not. And presumably if he's getting worse with steroids, you don't know if this is just progressing and needs higher levels of immunomodulatory therapy like plasma exchange or something like that, if we believe this is transverse myelitis, or if this is a point to pause and look at the imaging again, repeat some imaging, and even consider getting some vascular imaging here to see if this patient has a sarcoid, and maybe that explained the old 7th, or maybe not, or has subclinical sarcoid incidentally, truly incidentally, and has a true unrelated pathology, and this is actually a spinal dural AV fistula. So I suspect there was more imaging in this patient's future for us, past for you. And what did you find there, Doug?
So first we went back to the old imaging and went down to the basement to the neuroradiology library and looked very, very carefully at the sagittal cuts, particularly of the L spine, and saw no flow voids. We looked for these kind of dorsal venous engorgement, which there's a great paper from Vanya Douglas from 2012 that talks about the MRI characteristics of dural AV fistulas, because that's exactly what we're thinking. And I'll just take a moment to say that the only reason worsening with steroids with dural AV fistula was in my head at all is because of something that Aaron Berkowitz mentioned at the last talk that happened around this. And of course, there were attendings in the building who knew this. But my awareness of it came from a virtual morning report, a neurology virtual morning report, a student morning report. So I wanted to highlight that. There were no flow voids that we saw. We talked a lot about, the imaging characteristics of the cord, which were not typical for sarcoidosis. We knew that from the beginning. There was no subpial enhancement, which is kind of this very peripheral enhancement that you see that kind of just abuts the pia and can be nodular. There was not a trident sign. We actually thought there was a trident sign, our team did, but it turns out that trident sign, like Aaron mentioned, is a post-contrast finding. It's not a finding with the pre-contrast or the T2 signal. So there was not a trident sign. So there were a lot of things that were odd. We repeated the imaging with thin cuts, with the Fiesta sequence is what it's called at UCSF. And on the following morning, we got those back and there were the flow voids. There were some engorged venous structures behind the lumbar cord. And at that moment, we went and talked to neurointerventional radiology and, talked to them about this case. We're trying to see how quickly we could get her a spinal angiogram. They told us it wouldn't be until next week. Excuse me, I was saying her, but this patient is man. His exam was day by day, this was about a 3-day period, was getting a little bit better. We had to make the decision about whether or not to continue the steroids. And our concerns were, just as were mentioned by Aaron, and some other folks, especially on the chat, were, is this infection? Is this some atypical progression of what we think must be neurosarcoidosis, given the systemic finding? Or is this a dural AV fistula? And he has a DAVF plus this incidental finding of sarcoidosis. So the steroids were continued at the time after a lot of discussion. This is before we had the imaging, and then they were stopped once we found these flow voids and we kind of took a pause. The neurointerventional radiologist actually came in on a Saturday and did this past Saturday and did a spinal angiogram and found a right T10 epidural AV fistula that was supplied by 3 different branches on both the ipsilateral and contralateral side. So that basically was the diagnosis, that this patient has both incidentally found pulmonary sarcoidosis and a spinal epidural dural AV fistula at T10.
My goodness, I'm going to have to always now have a morning report bias for Doug's cases that whatever the diagnosis seems to be on the final aliquot, there's another aliquot with the final diagnosis, because he and I recorded what will come out on the podcast soon with a case with him. And I think we were booked to talk about it for 40 minutes and talk for about 3 hours by the time we got through everything. So that'll be one to listen to on double speed when it comes out. So fantastic. I know we ran over, but this was, although a somewhat gourmet diagnosis, right? An important chance to review the differential diagnosis of bilateral leg weakness and localization generally to the quad or below, or rarely medial hemispheres, and to think about when to also invoke the cauda equina. And then with this time course, thinking infectious inflammatory, but with this really impressive fluctuation. And in this age group, this tends to be a condition that's more common in older men, 60 and above. You have to think about this dural AV fistula. And this is one of these diagnoses where I got the advice once for anytime you see a stroke or a hemorrhage, ask yourself if it could be venous, or you'll always forget to consider venous etiology. And usually it's not, but make sure you check that mental box. And I think for spinal cord, this is sort of a great imitator and an often missed diagnosis of a dural AV fistula. And these present with a fluctuating myelopathy, usually more subacute to chronic. You heard I mentioned it earlier, my differential, but sort of tossed it away because this seemed to be progressing acutely. But when you hear about fluctuation, when you hear about worsening with LP or steroids, many of these patients are diagnosed on their scan with transverse myelitis. And we had a case several months ago that I think was presented as transverse myelitis that I was more convinced was a spinal cord infarct, if I recall. So there's a growing literature on sort of debunking sort of this idea of just making a clinical radiologic diagnosis of transverse myelitis and calling it quits, when there's actually many other pathologies that can look like a transverse myelitis cause diffuse cord edema, but have varying etiologies. And some of those are vascular. So this is an AV malformation. And for whatever reason fluctuates like this. And so always important to have in the back of your mind with a subacute, especially fluctuating spinal cord syndrome, could this be a dural AV fistula? Because these are often missed on neuroimaging. As Doug mentioned, you're looking for a particular finding of sort of enlarged flow voids dorsal to the cord. Those will appear sort of like dark circles in sagittal section, but sometimes you don't see them. These are very dynamic. And I even heard about a case in a grand rounds or a chief rounds sort of presentation where patient actually had a spinal angiogram and they didn't find a dural AV fistula. The patient went to another hospital, got a second opinion, and that radiologist found the dural AV fistula. And it was obviously a big deal that this was missed. This very concerning diagnosis was missed, quote unquote. But the radiologist will tell you these are very dynamic and you really have to be very patient. They go into every radicular artery at every level. You inject, you wait. And these are dynamic lesions, and sometimes they're not even caught on a spinal angiogram, which is obviously the most sensitive test. So hopefully this patient got coiled and this got better. But very interesting that he also has incidental sarcoid and a lot of clues you astutely placed to lead us down the garden path of thinking this could be inflammatory and particularly sarcoid. Great. I know we've run over because there was some extra complexity thrown in at the end, which is great for those of you who have stuck it out with us. Thank you. And I'm not sure if it's Gabby or Priyanka doing teaching points, but whoever is, if you'd like to give us a brief overview of some of the take-home points, that would be great. And then we'll wrap up.
Yeah, it's gonna be me. So thank you for this case. It was really, really interesting, especially the final part. Very surprising. So we learned about a patient who was 60-year-old, a male that presents with a previous history of right Bell's palsy 15 years before. And she presented with progressive gait difficulty. He presented with progressive gait difficulty and falls. And we discussed first how to approach gait difficulty, which was the chief complaint of this patient. And we have to differentiate between neurological causes and non-neurological causes. So Matthew mentioned some non-neurological causes that can be orthopedic problems, asthenia, system issue like sepsis, anemia, or hypotension. And the neurological causes of gait difficulties are cerebellum, sensory problems, especially proprioception, weakness, then we have to look for upper and motor neuron signs and higher order problems such as Parkinson's disease or normal pressure hydrocephalus. We also have to think about lower limb involvement without upper limb involvement. We have to localize it in the spinal cord, especially look for lower and motor neuron signs as well. We discussed a little bit about some etiologies for spinal cord lesions, which are vascular, neoplastic, compression, like disc vertebral collapse, infection, and inflammation. Aaron also remembered that the term transverse myelitis is used for inflammatory process, for example, multiple sclerosis, neuromyelitis optica, or after some infections. And this case was very surprising in the end because the repeated image shows MRI with flow voids, and the person had the classic presentation of fluctuation after lumbar puncture or steroid use, which happened both in this case. So thank you everyone for today, and thank you for the case again, Douglas.
Thank you for those amazing learning points, Gabby. If I could just add one other one that really floored me and was a big, in the cognitive biopsy of this case for me and my team was, for whatever reason, and I can't find much on this in the literature, spinal cord processes can lead to enhancement and edema in the cauda, in the nerve roots. And that was something that threw me off. I'll certainly admit that I think of a spinal dural AVF as predominantly a myelopathy, something that's limited to the spinal cord. The fact that there was edema and enhancement in so many of the nerve roots, so peripheral nervous system, made me think that this was more likely something infectious or something infiltrative or something autoimmune. But talking to some experts and people who've seen many more of these DAVFs than I have, apparently this is something that you see, and I haven't seen it really documented in a lot of the case series, but that was a big learning point for me, is that you can have root involvement in not just dural AVF, but other spinal cord processes for some reason. If anybody knows, I'd love if anyone has any thoughts, Aaron or anyone about that.
Yeah, I hadn't heard that specifically, but it doesn't surprise me, at least for dural AVF, just because I presume the venous drainage of the nerve roots is shared with the cord. I don't know the posterior spinal circulation as well as I do the anterior circulation, which we all memorize because of anterior spinal artery syndrome. But I feel like I was aware of that symptom, that sign, but I hadn't thought about it. And my guess would be that you're just getting the same process in the cord. That you have venous engorgement and you have back pressure, and that's eventually going to cause things to leak. But that's not a very elegant explanation. Let me know if you find a better one. Fantastic case and fantastically presented. Doug, definitely could be another clinical reasoning case to write up. I know you have a big stack of these, but this would be a great one to do in the neurology resident and fellow section, where if you want to get your reps on cases just like this, that's a great place. Gabby, thank you for scribing and teaching points, and Priyanka, you were doing some as well. I had trouble following the cursor, but you both kept up with a lot of information from Doug and from me. And Raphael and Mathieu, great discussion of a complicated case. And let's not forget one of today's most important teaching points from Mathieu, the correct pronunciation of Guillain-Barré syndrome, Guillain. We have to keep practicing that, or we'll keep saying Guillain, which is how I said it for many years as well. So key teaching point from Mathieu.
Syndrome de Guillain-Barré.
Syndrome de Guillain-Barré. Guillain-Barré-Stroll était l'original, mais ça c'est un autre sujet. Okay, fantastic discussion, everyone. Thank you for this wonderful case and wonderful discussion. For those of you who stuck it out for almost an hour and a half, thank you, and look forward to seeing you again next Tuesday.